will discuss the updates on treatment of thyrotoxicosis and thyroid induced orbitopathy. Madam is consultant endocrinologist at Narayana Super Speciality, Nanded. She has received many awards for presentations and has multiple publications. For chairpersons, I invite Dr. Sameer Malviya, Senior Physician in Akola, and Dr. Vaibhav Chakravarti, a renowned diabetologist from Yavatmal.
Hello. A very warm thank you for patiently listening to all endocrinologists harping from morning to it is almost 5 p.m. and I really appreciate your patience and thank you for sitting for the last lecture. I was wondering who will be there for the last lecture. Anyways, I will be talking about, chairpersons, can I start? I will be talking about update in the treatment of thyrotoxicosis and a short overview of the thyroid-associated ophthalmopathy. Anyways, now coming to the first, before we going on to talk about thyrotoxicosis and its management, we should be knowing just in general about the thyroid physiology. First is the headmaster, which is the hypothalamus. Second comes the pituitary, and third comes the thyroid hormones. The TRH is released, which stimulates the pituitary, which secretes the TSH, and which further stimulates the thyroid hormones, which secrete the T3, T4, and which further give the negative feedback. If T3, T4 is more, so the TSH will be less, and it will further suppress the hypothalamus. Now, other part of the diagram is a basic thyroid cell, which you can see, and all the TSHR receptor, which is seen, the sodium iodide symporter, the TPO. These are all the things which we measure normally. And now the newer therapies which are coming, the targeted therapies are coming, which are all related to this. Now this basic algorithm, Dr. Altamash has already spoken about it. Low TSH, high TSH, what we should do about it. So measuring the pre-T4 levels, and I will be talking about that. Measuring the pre-T4 levels, if it is high, then it is thyrotoxicosis. If it is normal, it is subclinical hyper. When the pre-T4 is high, that hyperthyroidism, there are two aspects about it. One is primary hyperthyroidism, that is the hyperfunctioning of the gland itself, and the second is the destruction of the thyroid hormones. So all these causes are over here. So the Graves' disease, toxic multinodular goiter, toxic adenoma, congenital hyperthyroidism, and even pregnancy-related hyperemesis. All these things are because of the excess functioning of the thyroid gland. The thyroid gland is producing more T3, T4 hormones, whereas the remaining, that is a thyroiditis, drug-induced or excess iodine intake or excess thyroxine hormone ingestion, they are all excess thyroid hormones either from outside or it is because of the de novo destruction of the gland. Because of any viral infection, like in COVID, we saw a lot of cases of thyroiditis, that is the destruction of the thyroid epithelial cells, which is causing the release of the pre-formed thyroid hormones. So this is very important. Now, this is the basis of how we are going to diagnose thyrotoxicosis. First is the measuring the TSH levels. Second, the new thing, the update. Now my topic is essentially update because what is the new thing? What are the newer things? We all know how to diagnose thyrotoxicosis. We all know that we have to do T3, T4, TSH levels. We know the nuclear scan which is available. But the newer thing which has come are the TRAB antibodies and the emerging evidence of, increasing evidence of using ultrasound in the diagnosis of thyrotoxicosis. So this is the overview of my talk. I will be talking what's new in diagnosis, in management, in children and in thyroid-associated ophthalmopathy. So what we know elevated T3, T4 levels will suppress TSH. They are divided into two causes. One is the primary hyperthyroidism and the excess thyroid hormones. And what we know, how we diagnose it, the first thing which we go that the T3, T4 levels, if they are elevated, T3, T4 levels are elevated, we have a doubt, we can, and if it is available, we do the radioactive iodine uptake scan. Now what you can see, where I practice, that is in Nanded and in Akola also, radioiodine uptake scan which is not available, but just I am giving you a picture of it is, the one on the right where both the thyroid glands are seen, they are seen black in color. So that is the thyroid gland is functioning more. So that is the more thyroid hormones are generated. And one on the left side is you do not see the thyroid glands at all. There is no uptake over there. What you see, the black spots are the salivary glands which are over there. So that is thyroiditis. That is destruction of the thyroid hormones which is taking place. And this is also hyperfunction of the gland. This is like a black spot, black bindi. What you can see, this is a toxic adenoma or a nodule in the thyroid which is hyperfunctioning so much that it is almost taken in all the IV, and the rest of the gland you do not see at all. So the newer updates, the newer guidelines which have come up are one which are in 2016 and ones in the 2018. Now in diagnosis, what is new? Now TRAP is TRAP antibodies, which are everybody was talking about it. Dr. Altama spoke about it. Dr. Jayant also spoke about it. TSH receptor antibodies, they are very relevant to us, especially for us practicing in third-tier cities like Akola and Nanded, where RAI is not available. And next is the thyroid blood flow on the ultrasound. So I'll be talking about TRAP. So what is this TRAP? And what is the best test for measuring TRAP? And what are the indications of using TRAP? How is this useful? And should it be measured in pregnancy? These are the 5 things. Now what is TRAP? TRAP is TSH receptor antibody. It is a G protein coupled which undergoes cleavage, and basically it is divided into 2 chains, A and B, and it's the A subunit which causes the all autoimmune phenomena. So this is the TSHR receptor which is present, and the 3 things, that is the thyroid stimulating antibodies, TSH, SCG, they all act on this TSHR receptor. In pregnancy which we see, it is through this HCG how the TSH receptor is stimulated, and that is why we see a suppressed TSH in pregnancy, gestational thyrotoxicosis. This is the reason, because HCG binds with the TSH receptor. Now this is the TRAP. Now these TRAPs, what you can see, one is the thyroid stimulating, one is the thyroid binding, which is the inhibitory one, and one is the neutral ones. Now the stimulating ones are the most important, and why it is important? Because it is seen commonly, mostly it is seen in 99.9% of cases of Graves' disease, that is primary hyperthyroidism. The blocking antibodies, why they are important? Because sometimes we can see a patient of thyrotoxicosis and he is a case of primary hyperthyroidism, starting on treatment, suddenly next time within 6 months his TSH is more than 100, within 6 weeks his TSH, that is probably the patient might be having thyroid stimulating and blocking antibodies. So what we need to remember, we just don't need to go into the details, that TRAP antibodies are needed to be measured and they are easily available, and there are 2 methods which are available. The one which is important for us is the 3rd generation TBI assays, which are generally available. The Metropolis lab does it, but they do not differentiate in the type of the antibody. They do not say whether it is a thyroid stimulating antibody or whether it is a thyroid inhibiting antibody. And the bioassays, which are usually not available, they are in the institute level. So what we can see, all the Graves' disease, almost 99% of them have positivity. Hashimoto's thyroiditis, where sometimes the case is like Hashimotoxicosis, where it is a transient destruction of the thyroid hormones because of Hashimoto's thyroiditis, they may have 1 to 2% positive, and in healthy individuals, less than 1%. So if you are going to do TRAP antibodies, they are very kind of very specific for diagnosing Graves' disease, and this is very useful in pregnancy, when we want to differentiate between gestational thyrotoxicosis or whether it is primary hyperthyroidism, because anyways RAIU scans are contraindicated in pregnancy. So we need to know that if the 3rd generation assays are not available, then RAI needs to be preferred. And we need to remember the normal level too, that less than 1.75 is the normal range. Now when do we use it? There are 3 things to it. First, when there is a diagnostic dilemma, then deciding the nature of the therapy, and in pregnancy, to monitor the outcomes of it. Now diagnostic dilemma, as I already told, that to differentiate between thyroiditis and Graves it is going to be positive. Higher the TRAP levels, that is more is the autoimmunity, more likely that it is going to continue longer, and thyroiditis usually it will be negative. Even subacute painless thyroiditis, less than 1% of it is seen, thyroiditis, that is what I again said, destruction of the thyroid hormones, it is negative. So we can differentiate, and also when we need to decide regarding the stopping of therapy. Now, usually when we start the treatment of anti-thyroid drugs, there are three types of drugs which are available. That is the propylthiouracil, methimazole, and carbimazole. So you usually started, and the treatment is continued for around 18 to 24 months. So at that time, TRAB is useful. So if TRAB is negative and if the patient is of low risk profile, you can stop the ATDs easily. Means you can stop it with some kind of confidence, because a very few number will relapse. That is 20%, and they will relapse at the end of 1 year. Second is that if they are TRAB positive, that time we should consider definitive surgery, a definitive treatment. That is, either we send them to a radioactive iodine ablation, or we consider surgery. Or still, if they are TRAB positive, we can still consider long-term ATDs. And these long-term ATDs have a subset to it, that is, they are younger patient and have a stable disease, that they are mild and like they are easily well controlled on 5 milligram of carbimazole, or very low dose or 10 milligram of methimazole. They are very easily controlled, so we can think of continuing them for a prolonged period. Now, TRAB in pregnancy, it should be measured, because it gives us a lot of information. When to measure, we should remember it. It is the first trimester, when the patient has been diagnosed as case of hyperthyroidism, Graves' disease, we should measure the TRAB. If the levels are elevated, again we do it at 18 to 22 weeks. And again, if it is elevated at 18 to 22 weeks, re-measure it again in 30 to 34 weeks. Now, why this is important? Because first of all, measuring it in the first trimester, it is easier to understand that we can take the patient off ATDs. If a patient is, say, pregnant, and if the TRAB is negative, we can think of even stopping the ATDs, or we can start tapering it very fast. And the next is that if the TRAB is very high, then the likelihood we should do the fetal monitoring. So the case one of the doctors, he had mentioned that the baby had got a TSH of more than 400 and mother was on anti-thyroid drugs. So this is where TRAB would have been very useful. And like Dr. Altamash also said, medico-legally also it is, because the tests are available. It is available for around 2,000 to 2,500 rupees from Metropolis lab. And it is not like we should reserve it for precious pregnancies. Now each pregnancy is precious. Now nobody has 4 or 5 children, everybody has 1 or 2, so every pregnancy is precious. So if we have the facility, we should just get it. It's just a blood work to be done. And we should remember that if the TRAB levels are more than 5, that is 3 times the normal limit of the assay, then the chances of having a hyperthyroid neonate increases. And all the hyperthyroid neonates had the mothers who had TRAB levels more than 5. Now, another controversy, I will not go into much into it, that if thyroidectomy is often followed by decrease in the TRAB levels and decrease in ophthalmopathy also, whereas RAI, that is radioiodine ablation, causes a transient increase in the TRAB. So if we have a young female and who is thyrotoxic, and if she's having a certain amount of Graves' ophthalmopathy also, and she is planning conception in near future, radioiodine, now there are a lot of arguments, this is not yet come in guidelines, but there are a lot of arguments that we give the patient thyroidectomy because that will reduce the autoimmune titer and also decrease the Graves' ophthalmopathy. So this may be a good option. Now coming to the next thing which is making life easier for us is the Doppler ultrasound, which is measuring the peak systolic velocity in cases of thyrotoxicosis. This is very easy for us, that especially cases which are cases of mild Graves, which have a T3, T4 level, say like 14 is there, and T3 just 1.8, 2, and TSH is separate, or we are confused whether it is mild Graves. So this is very useful. So peak systolic measurements of the thyroid artery have become accurate and flexible with excellent reliability. The cutoff volume for peak systolic velocity is usually 40 to 50 centimeters per second. Now either superior thyroid artery velocities are measured or the inferior thyroid artery velocities are measured, you can speak with the local radiologist, and this is a picture. In this, how the increased thyroid blood flow is seen over here. Now, anti-thyroid drugs coming to the management, nothing is new. Actually, in the past 70 years, nothing new has come in the drugs which have been approved for treatment of thyrotoxicosis. So this we all know, like I said, carbimazole, methimazole, PTU. Now 10 mg of carbimazole is roughly equal, it is metabolized, that's why it is roughly equivalent to 6 mg of methimazole. Now initial dose usually it is 10 to 30 mg. PTU to this conversion is around 1:20. 5 mg of methimazole is roughly equivalent to multiplied by 20 times around 100. So PTU is given 100 mg every 8 hourly and divided. Now this is a rough guide given by the ADITI guidelines that if the free T4 is 1 to 1.5 times the upper limit of normal, start with 5 to 10 mg of methimazole. If it is 1.5 to 2 times, give it around 10 to 20. If it is 2 to 3 times, give around 30 to 40. Now this will not be going, I think Dr. Jain has already said how it crosses the placenta and the side effects have already been dented. Now this is a newer thing. In surgery, for toxic adenoma and toxic multinodular goiter, the treatment remains means the surgical indications have been the same. But for Graves' disease, both the European guidelines and the 2016 ADITI guidelines say that total thyroidectomy is preferred over subtotal thyroidectomy. Because there is a possibility of recurrence of hyperthyroidism with by using subtotal thyroidectomy, and also there are not much complications in the hands of a stable surgeon with whether you do total thyroidectomy or subtotal thyroidectomy. So good surgeon, what is a good surgeon now? Who does at least 25 surgeries, thyroid surgeries a year? So we should remember that whenever we are referring it to, we should always refer it to a high volume thyroid surgeon. The chances of complications are much less, and also the chances of complications for us are also low. We don't have to manage hypoparathyroidism of them. So another take home is that prefer total thyroidectomy over subtotal thyroidectomy for Graves' disease. Now there are still a lot of unmet needs in thyrotoxicosis treatment, that is in the management of especially the Graves' disease. Because a lot of patients, most of these carbimazole, methimazole, PTU, they are with side effects. Many of them they don't respond to it, and then we send them for definitive treatment. Now, definitive treatment, what it does, it renders the patient hypothyroid. Initially, the patient is losing weight, कितना भी खाओ weight loss हो रहा है, but suddenly you render them hypothyroid. Doctor, आपने वो दवाई पिला दी, तब से हम फूलते ही जा रहे हैं. This is what it happens. It renders the patient hypothyroid. And so, what is needed are drugs which elicit a specific targeted response without disrupting the functioning immune system. So, these are the newer therapeutic horizons which are there, the B lymphocyte immunomodulation, the immunoglobulin recycling. The TSH receptor signaling is the most promising because it acts at the receptor itself, and the immunomodulatory peptides. This I will not go into the details of it. These are the trials in various stages which are going on. That if you see at the lower side, the potential efficacy in the Graves hyperthyroidism with TSH receptor therapy is the most promising. So this is the overview of the management. Start with methimazole, carbimazole. Try avoiding PTU because we know PTU can cause fatal hepatic necrosis. And believe me, if PTU has hepatic necrosis within, today the LFTs have started rising, by tomorrow the patient is in fulminant hepatic failure. So as far as possible, try avoiding PTU and start with methimazole or carbimazole, and then as we said, give it for 18 to 24 months, see the response, measure, track. If not responsive, do a definitive treatment. Now newer guidelines are come. I don't know why so many guidelines come. Anyways, but 2022 pediatric Graves guidelines have come. So more or less it is the same, but what is there is that the baseline CBC and LFTs are recommended. In adults, we do not recommend to monitor the baseline. We usually do not. It's always better we do it, but it is not recommended. So, but in children, it is recommended to measure the baseline CBCs and LFTs. PTU is not to be used in children as far as possible because unacceptable risk of hepatic failure. Now, there are two approaches. That is the dose titration approach or the block and replace regimen is there. These are the starting doses. Start with a lower dose 0.15 to 3 milligram per kg and increment subsequently. And repeat the monitoring at 2 to 3 months. If it is euthyroid, you can reduce the dose by 25%, hypothyroid reduce by 50%, hyperthyroid increase the dose by 25%. For first 4 to 6 months, be always guided by the thyroid hormone concentrations. And beyond 6 months, you should, along with the normal thyroid hormone concentration, be guided by the TSH measurements also. Block and replacement, it is here TSH is expected to kept in normal range. Here we directly try to render the patient hypothyroid and start him with thyroxine, which is age and body appropriate. Now the difference in Graves in children and Graves in adults is that the treatment duration can extend to 3 years and their relapse rates are higher. So treatment duration can extend up to 5 years also. Now radioiodine is contraindicated in less than 5 years. If at all you do it 5 to 10 years, you can still do it. More than 10 years, you can do it, and you aim for a thyroid ablation so that you do not leave any thyroid gland which has already received radioiodine and a potential for thyroid malignancy in the future. However, the malignancy data which is there, it is from the Chernobyl disaster, and total thyroidectomy is always a choice for Graves' disease. Now the UGOGO guidelines are also there for the management of thyroid-associated ophthalmopathy. Now there is a clinical activity score that is which is there when we see the patient who has a thyroid ophthalmopathy. This is the clinical activity score, how we measure it. Then also they are divided into mild Graves orbitopathy, moderate to severe and sight-threatening. Now what is important for us as physicians, we need to know that selenium supplementation has come. For mild and active GO of recent onset, we can give selenium supplementation till 6 months. This will improve the eye manifestations and the quality of life and prevent Graves orbitopathy pro to severe. Now selenium is like commonly available in thyroid tablets, so we can give them the benefit. Now glucocorticoid prophylaxis, why it is important that before we send any patient, say 18 to 24 months of ATD is done, and you decide now this person needs definitive treatment, you send the patient for radioiodine. After 2 years, the patient comes with a big proptosis. So we should always remember there are a subset of patients that is high risk for de novo progression, which are high TRAPS, which are smokers, and which have severe uncontrolled hyperthyroidism. They have a risk of having radioiodine induced ophthalmopathy, because what does radioiodine do? It increases the TRAP levels. Now TRAP levels, the TSHR receptors are present in the orbits also. So the orbits, they come out. So by giving RAIU, you can, if the patient is having normal eyes, the patient can come back to you and tell you that because of you, I got ophthalmopathy. So we should always remember this: high TRAP, smokers, severe uncontrolled hyperthyroidism. We should think about glucocorticoid prophylaxis. Now these are the various treatment. Mild Graves orbitopathy, it's usually symptomatic. For moderate to severe and active Graves orbitopathy, IV glucocorticoids is the line of treatment. Usually the treatment duration is continued for 6 weeks. 6 weeks of 500 milligram every weekly. Then you go on to 250 milligram. Now the newer thing which has come in this guideline is the use of mycophenolate mofetil or mycophenolate sodium. 0.72 gram of mycophenolate sodium is equal to 1 gram of approximately of mycophenolate mofetil. So this has come in the use of Graves orbitopathy. Moderate to severe, there are multiple second line treatment available, and teprotumumab, which is there, which is the IGF-1 receptor antagonists which are available, and these have been approved by the US FDA, and it is available in the US, but it is still, because of the cost concerns, it's not over here at least. So these are the newer therapies which are available. Sight-threatening GO, pulse therapy is a way to go, and sometimes decompressive surgeries are also needed. So now to summarize my talk, Now TRAP is a simple laboratory test which can be used for diagnosis and management purposes. Role of Doppler is important in cities where RAIU is not available. Antithyroid drugs, RAI treatment for TNMG, toxic adenoma remain the same. Total thyroidectomy is a treatment for choice for Graves' disease. Mycophenolate is added as a first-line therapy for IV glucocorticoids in tau, and RAI is contraindicated less than 5 years of age. Thank you. I hope I'm finishing time.
Very well how to give approach to patients of hyperthyroidism. If there are any questions, the session is open for questions.
Thank you, ma'am. I request the faculty and chairpersons to please proceed towards the center of stage.
Request the chairpersons to felicitate the faculty, and I also request Dr. Apurva Jaiswal and Dr. ADITI KABDE to please come forward and felicitate chairpersons.